Hi, everybody. My name is Alexandra. I hope you all are doing great on this Tuesday morning / afternoon, depending on where you're joining. We're going to get started here in just about 2 minutes. Just some kind of logistics about Zoom. Feel free to keep your video on. We will be keeping everyone in the conversation on mute until we get to a Q&A section later on in the panel. But please feel free to communicate in the chat box. Another note is that this is our first time doing an event on Zoom for a panel. So we would love your feedback after the event is done, as well as your patience as we get some other things sorted out as we get started today. Thank you. Okay, so we're going to go ahead and get started. So today we will be talking about the ways that race and socioeconomic status, as well as unequal access to proper education and healthcare, can make a visit to the gynecologist turn away from an intimate time of a woman learning more about her health and instead into a time of confusion, disappointment, and long-lasting pain. Today, we are going to be joined by some incredible speakers who will help us to learn more about these disparities, as well as point us towards a way of thinking about how we can change the way that women are receiving healthcare today. Our first speaker is going to be Dr. Chemtai Mungo. She is a trainee in AIDS prevention studies, a Fogarty Global Health Fellow, and a UCSF OBGYN. Welcome, Dr. Mungo.
Thank you. Thank you for having me.
Our next speaker will be Nikki Mahendru. She is a Duke University neuroscience major. She has minors in global health and economics. Welcome, Nikki. And our third speaker will be Dr. Megan Huchko. She is an associate professor of OBGYN and global health. Dr. Huchko is also the director of global reproductive health at Duke University. Welcome, Dr. Huchko.
Sorry about that, I was muted. I will be introducing our moderators. You just heard Alexandria speak. She is the Associate Director of Operations at the Center for Global Women's Health Technologies, and I'm Ashley Deans. I am our Communications Specialist. We're going to be moderating this panel today, helping facilitate the Q&A. If you have any questions, you can send a message in the chat to either one of us or to everyone, and we'll respond to it. Before we get started, I want to tell you a little bit about the Center for Global Women's Health Technologies, where we work. In 2013, Dr. Nikki founded the center with the mission of empowering women and empowering trainees to create meaningful solutions in the lives of women and girls globally. This center, since its inception, has catalyzed new research activities and the development and commercialization of several technologies that advance prevention and treatment of cervical and breast cancer. We're working together to advance our center's mission of erasing disparities in women's health. While most of the individuals in our center come from a science or engineering background, Alexandria and I have the opportunity to focus more on the social and community engagement aspect of our mission. Over the summer, Alexandria and I cultivated a blog series that addressed disparities in women's healthcare. We've now turned that blog series into a panel series. So I'm really excited to kick off this panel by introducing one of our blog post authors and panelists today, Nikki.
Hi, everyone. Thank you so much for having me. I'm really excited to be a part of this panel. It's my first panel. And yeah, that's about it.
All right, so each of our panelists is going to have an opportunity to speak for a little bit. We're going to let Nikki go first. She's going to share about some of her observations, shadowing in gynecological offices, and then we'll go from there. So I'm going to mute myself now and we'll let Nikki speak. If I may make a suggestion, I would suggest putting Zoom in the speaker view so that you're really just getting to see who the speaker is. All right, go ahead, Nikki.
Great. Thank you so much for having me today. Today, I want to talk a little bit about my experience as retold in the eyes of a student and hopefully future women's health practitioner about what it was like working in an OBGYN office. As you may have read in my blog, I firmly believe that it is this exact office that can be the birthplace of a woman loving her body or hating it. It's an extremely intimate setting, and as I saw it, it was a place where providers have the power to help women make their health a priority. In the same vein, if providers are inadequately equipped to probe beyond the physical manifestation of their patient's health and wellness, they can easily lose the trust of their patients. You may be asking yourself, what do I mean when I say beyond the physical aspect of health and wellness? I mean the broader determinants related to socioeconomic status and racial and cultural identities that contribute to the care that patients seek and the care that they receive. I want to dive deeper into two specific instances where I saw the trust of the patient lost or regained based on her experience in gynecology, and how the act of listening plays an important role in bridging the disparities faced by women of different racial, cultural, and socioeconomic backgrounds in women's health. I wanted to start off by talking about my mom. My mother is a successful, hardworking corporate superstar. She's an advocate for women's empowerment within the company that she works, and she actively mentors women at the college level to the professional level. Yet in the space of women's health, beyond the care that she received when she had my brother and I, she had her first experience with a gynecologist at the age of 45. She always knew she had to make her health a priority, but being that she was always incredibly busy, she found it a simple task to keep putting off. Slowly, after some coaxing and joking about how this gynecologist's office is my home away from home, she agreed, and she made her first appointment in the spring of 2019. I called her after her visit, so excited to hear whether she shared the same joy that I felt in feeling comfortable and having agency over our bodies. She sounded subdued and a little bit upset. Then she told me her provider was in the room for 5 minutes, completed her annual exam, and was out the door. The 20+ years of questions, hesitancy, and resistance in the realm of visiting a gynecologist that had built up were reduced to a 5-minute clinical exam. This was no reclamation for my mother. She knew that her hesitancy to visit the gynecologist stemmed from the taboos surrounding women's health in the cultural setting within which she was raised in India. It cemented her unawareness and eventual unwillingness to visit, but she also thought that this one visit could open her up to the possibility of learning more and caring more for her own body. As the phone call ended, her words, "I don't know if I want to visit again," continued to ring. Her trust in the system, which she had been so skeptical of, was lost. She had longed for an open conversation with her provider to address why she had never been before and to give her a reason to go again beyond the annual pap smear and mammogram. In speaking with her further, she said she had felt insignificant and small in that moment, relegated to the status of just another patient. Her story that was wound in concerns, questions, and revelations about escaping the paradigm of women's health as it was defined by her Indian heritage was shut out. She was left believing that yet again, the realm of women's health is just not for her. The next instance that I'd like to talk about is that of Carmen's. Carmen was a 65-year-old woman and she only spoke Spanish. Her daughter was not in the office with her in the moment to help her, so she relied only on the medical translator in office. Similar to my mother, this was her first time visiting a gynecologist in the United States. During her visit, it was clear that she was in a lot of pain, so the visit was treated as a reproductive pain visit. Within the 30-minute time slot that's spent on new patient visits, the time that Carmen spent with the provider was just a fraction of the time that the medical translator and I had spent with her. The visit summary, as told by her provider, was a simple diagnosis, a pelvic organ prolapse, and a simple solution, a pessary and physical therapy. However, if you asked the medical translator and I to relay Carmen's story, we learned how she had been in pain for the last year and had tried to ignore it so not to be both a financial and emotional burden on her daughter. We would tell you how she had been forced to have a C-section during her delivery in Peru, and she had never wanted to step foot in a gynecologist's office again. We would also tell you she had waited this long to come into this specific office because her previous experiences with healthcare providers in the US had been marked by broken translations, misinterpretation, and frustration. Yet we would also tell you how Carmen had worked the majority of her life to send her daughter and her son to college to become engineers. We would also tell you that she had recently been learning English using Rosetta Stone. Finally, we would tell you that Carmen had scheduled a follow-up appointment and she had eventually followed through with her care directive. In the moments that we spent with Carmen, she became more than a green box on the day's patient schedule. We were effectively able to communicate with her and both literally and figuratively translate her previous history, her worries, and her future goals to the provider in order to establish a care directive that was the best economic and cultural fit for her. But it was more complicated than that. It was the medical translator and I who had established an equitable working relationship with Carmen. She felt comfortable with us like we with her. I couldn't help but think more about what would have been had the translator not been there that day. Would Carmen have been turned away? What about the overeager student Shadow that was so deeply curious about the life that Carmen lived? Would we have uncovered her story then? These instances, while anecdotal, paint a picture of the reality of women's healthcare and gynecology in the United States. They personify the stories behind statistics, like how minority women suffer a disproportionate amount of gynecologic cancer-related mortality, or how pregnancy-related mortality ratios for Black women, Native American women, and Alaskan Natives are 3.3 times higher than that of white women. While these statistics are also intertwined with the structural factors like access and quality of care, they are ultimately tied to the face-to-face interactions between provider and patient. In sum, these interactions in office are critical in establishing trust in the healthcare system for those who are skeptical and for those who routinely experience bias and discrimination. This ultimately creates a path for continued preventative care and reaching women where women's health was never a centerpiece for their lives. Thank you.
Thank you, Nikki. We're going to move on to Dr. Megan Huchko next.
Hi, everyone. Thank you for inviting me to speak today. It's nice to see everyone who was able to come to the panel. I see some of my current and former students, so I appreciate you guys being here. And thanks, Nikki, for such a great sort of way to start us off and really for writing the blog that inspired this. So I was asked to talk a little bit overall about racism and bias in gynecology or in OBGYN. And I know that the first panel really focused on that. And I want to talk about that both in general and in my own experience. I would say my first understanding about some of the structural and systemic factors that influence women's health started here at Duke when I was an undergrad, and I took a really amazing class called The History of Women in Medicine. And it outlined the sort of origins of healthcare and then the origins of women's healthcare. And throughout history, there's been sort of a undulating wave in which women have been able to use healthcare and be healthcare providers and find different levels of empowerment from both being a provider and seeking that healthcare. I say waves because some of the earliest examples of women's healthcare are stories of women taking care of women. And as more patriarchal structures were put into place and men took over healthcare in ancient times, you started hearing the terms such as hysteria. You started hearing depictions or seeing depictions of menses as dirty. You started seeing a real lack of ability for women to have control of their own cycles or their own fertility. And you sort of saw that sort of coming up and down throughout history, whereas women were promoted as healers and caretakers for women's health issues, women were centered and potentially felt more safe. We see that in the history of abortion provision and abortion rights in the United States, as midwives were the main healthcare providers until the middle of the 19th century. Abortion was something that was just fully understood as something that was a necessary healthcare service that some women would need to partake of in their lifetimes. And then as we saw a more codified OBGYN structure that was more male dominated, we saw the suppression of women's rights. And I think intertwined with that is what I know that the Global Women's Health Technologies Group has focused on is some of the racist history of the origins of gynecology. If you look at the early development of the speculum and the use of unanesthetized slaves as models or subjects of experimentation for fistula repair, we really see that with this same trend of lessening women and the centering of women in gynecology, we see more and more clear evidence of racism. And I think that while J. Miriam Sims was several hundred years ago, we still see clear evidence as presented in some of the stats that Nikki mentioned of continued both structural factors and individual factors that lead to racism in medicine, and I think more importantly lead to individual experiences and outcomes that prevent women from getting the care that they need. And then that lack of care leads to these poor outcomes, but also leads to a mistrust in the medical system that potentiates these poor outcomes among the women themselves and in their families. And I'll give my personal experience. I will give two examples of experiences that I think really talk about the unintended consequences of our racial biases in medicine. One is a specific example. When I was a resident, we went to Niger, a country in West Africa, or in the Sahara, it's not really West Africa, in Central Africa, to work on fistula repair with a group of urogynecologists. And this was a sort of group of highly experienced surgeons who were going for a short period of time to take care of women who had awful consequences of obstetric fistulas, which occur because women don't have access to appropriate obstetric care or postpartum care. And as a minor aside to that, when we were being introduced to the idea of the trip, the urogynecologist who took me gave a slideshow, grand rounds, in which he really praised J. Marion Sims as one of the fathers of fistula surgery without really any sort of discussion of some of his problematic history with experimentation on slaves. So we went to Niger and we did this rapid in and out. We were in the OR for 20 hours a day. We tried to take care of as many women as possible, really taking care of the very downstream consequences of something that needs to have a multilateral approach to address the structural factors that caused it. But the example that really struck me was when we operated on a woman who had a mass in her bladder, and everyone just assumed that it was a fibroid because they did a very rapid assessment and wanted to get her into the OR and get her out. And at the time of the surgery, it was noted, became very evident that it was a massive tumor in her bladder that really would have taken just an unbiased eye doing a complete exam and workup and looking at her weight loss and her symptoms and blood in her urine. But everyone was looking at these women as a single problem, that they had fistulas or leaking. And so this woman who had stage 4 bladder cancer at the end of her life was subjected to a pretty invasive surgery because she was only looked at with a single dimension. And I felt like that colored the way that I do global health because she was a poor African woman. She was not treated as a whole person and given the whole workup that she deserved before she was taken care of. And I try to remember that and bring that to my global health work every day. The second example is not such a specific example, but I will say that things have changed dramatically since I trained as a resident to when I did my fellowship and worked in San Francisco and now being back at Duke. When I trained as a resident, patients were openly and acceptedly racially profiled. They were mocked for their ethnicity. This was done by attendings. This was done by senior residents. They were mocked for their weight. We had different expectations that were overt. None of this was covert. And I trained at an Ivy League institution in a major urban area of this country. And it was okay to overtly talk about different pain requirements for people of different races and ethnicities. When I went to my fellowship in UCSF, the culture there was so dramatically different. And while not perfect from leadership down, they are teaching a culture of being patient-centered and exploring your own biases and racism and having a zero tolerance policy for the kind of stuff that I saw on a daily basis throughout my residency. And coming to Duke, I see that this continues as we now are seeing more diversity and inclusion training so that we can look into ourselves, our relationships with our teams, with nurses, with students, and of course with patients. And so I do feel like while nothing is perfect today and we're not there yet, I've seen dramatic changes that have come with both introspection, individual change and education, but systemic factors that can be put into place that can change the culture of these environments that will hopefully make a difference in the way that women feel coming into a healthcare setting so that they feel respected, they feel seen, and they feel heard, and that they're able to get the healthcare that they need in an unbiased manner.
Thank you, Dr. Huchko. That was very insightful. We're now going to pass it over to our third and final panelist, Dr. Mungo. So go ahead and take it away.
Thank you, and thank you, everybody. Thank you. It's good to be here. My name is Dr. Chemtai Mungo. I'm an OBGYN, about 3 years out of training. I was born and raised in Kenya and moved to the States when I was 17. So I sort of bring a dual lens to this issue, being raised Kenyan and African and having spent the last 15 years in this country, and really coming to appreciate the magnitude of structural racism and its effect on health and healthcare, and how I think as people, your prior speaker last week, and with this reckoning about racism, there's sort of a lot of mutually reinforcing systems of disadvantage that unfortunately people of color and Black people face, and that is a result of these health disparities that we're seeing. So just thinking about the history of this country, from slavery, Jim Crow, redlining, there's a lot of legacy of disadvantage, of lack of economic opportunity, lack of social opportunity, food deserts where people of color live, and the job discrimination, for example, significant effects on the kind of quality of healthcare that you will have, and hence poor health outcomes. And while things I think are changing, certainly the system needs a lot of kind of impetus to change it, because it's not currently quite set up for equity, given those experiences that Nikki and Dr. Huchko mentioned. So as an OBGYN in training, I trained in a high resource setup hospital where basically everybody had good insurance, and so you had really good care. We had access to high risk specialists, including gynecology, oncology, so the doctor that you would see if you have cancer, you need surgery for cancer as a woman, high risk MFM, very structured. And unfortunately, the way this country works, with healthcare being based on economics, and we know economics are based, are very tied to racism and access to opportunity. The women who had access to this kind of care are predominantly white, upper middle class, so people with good jobs. Following my residency, I currently work in a safety net hospital, which is a county hospital, because I wanted to care for underserved women. And the difference is very, very stark. And, it's sort of kind of the reality of structural racism that is happening every day. And you sort of have this separate and unequal access to resources that women have, that, if you really think about it, it's not surprising that we're having such poor outcomes. For example, as a trainee in a high resource setup, one of the big emergencies for women is obstetric hemorrhage. So women's bleeding really badly, you can't control the bleeding, and ultimately you have to decide, do I have to take out her uterus? Or if you have access to something called interventional radiology, where you can have a radiologist embolize the artery that's supplying blood to the uterus, you can save that woman's uterus and keep her ability to maintain her fertility. So as a trainee for 4 years in that high resource hospital in San Francisco, I only did one of those surgeries, which is called a hysterectomy, cesarean hysterectomy, because even though we had multiple bad hemorrhages, it was a high volume hospital, we always had interventional radiology. You could call them, and in 20 minutes, they'll be in the hospital, and they, would take the patient and they would embolize that artery, and, she would keep her uterus. And then now working in a county safety net hospital, like IR is basically non-existent because it's a really expensive service. And the way the US health system is set up is that county hospitals, are just very resource constrained. So, in the 3 years that I've been out of residency, somebody who only works about 30 or 40% clinically, I've had to see or do 3 cesarean hysterectomies. And so these are women of color who just don't have access to the technology that other women who are serviced by a well-resourced health system have. And this is an example of structural racism that is happening every day in this country. Another example is access to cancer surgery. Again, if you're working in a high resource setup hospital, we know that time from diagnosis to surgery is a huge determinant of how you will do, decreasing morbidity, mortality. So, high resource hospitals, they have the resources to have their own gyne oncologists who's trained, very well compensated. They will come in on the weekend because the system is tracked. Once you have a pathology diagnosis of cancer, there is metrics that you have to get that person in the operating room within XY weeks. And so these patients have, good access to care and better outcomes. And again, when you, in many sectioned hospitals, again, they don't have access to their own gynecologists because they're very expensive. And again, the system is set up such that these hospitals are very resource constrained. So you don't have these metrics where, a woman is diagnosed with cancer, the gynecologist who works in this hospital is sort of part-time, they're not really invested. And so time goes by before she gets access to this life-saving surgery. So this is how kind of mutually reinforcing systems result in poor care and worse outcomes based on race. And unfortunately, in this country, race is, or socioeconomics are tied to race because of the history of this country. I would say that there's multiple ways to address this issue, and young people coming up in medical school and undergraduate being aware and as you are is one thing, and being advocates and seeing as physicians and our work is not just in the operating room or in the clinic. We really have to advocate for a more fair system so everybody can have access to good health, because we know good health is mutually reinforced by many things. One thing that I think is really critical is diversifying the healthcare environment and healthcare in general, both from physicians, nurses, nurse practitioners, etc. So, the US workforce the US population has about 13% African Americans, yet Black physicians make up about only 5% of doctors. And when you look at academic faculty, they're even less, it's about 3.6%. And unfortunately, physicians need to mirror this society, because patients need to be cared for by people who look like them, not exclusively, but it's important because lived experience is something that you just can't buy. So if you have a physician who has lived experience of racism or economic discrimination or socioeconomic disadvantage, they can connect to that patient at a much greater level. For example, in the example of the clinic appointment, so, again, the US system is, you have these 10, 15-minute visits. But if if your doctor is an immigrant or somebody who speaks your language, that, the ability to empathize with the fact that this patient, is, English is not their primary language, they have different background. Their kind of understanding of healthcare is different. If you're able to connect on that level, then you're able to kind of push yourself, say, hey, I'm going to let my clinic run late, but I'm going to give this patient an extra 10 or 15 minutes because I know that she looks like my mother, or she looks like an aunt of mine, and I know that that aunt, needs more time because of sort of what they bring, from kind of cultural aspects. So this is a really crucial thing that I think we all need to work on, is diversifying the healthcare workforce and making sure that, there's more physicians who can serve these communities. Again, when you look at more diverse physicians are more likely to work in the inner cities. They're more likely to do research related to conditions that affects their communities. So we can't, as kind of a society, say we want to address health inequality when we are, there's so many barriers to becoming a doctor. As many of you know, it's very expensive, takes a lot of time. And again, that compounds, like, not many people don't have that luxury of 15 years of training because they need to support their family. So how do we remove those barriers to bring these people into the workforce that are critical to, sort of delivering what it is we are promising. And just lastly, I would say, with what's currently happening in the US, there's a lot of great conversations happening around equity that I encourage, all of you to partake in any and always, including being a part of this webinar. The New England Journal has had a series of really excellent opinion pieces in the last 6-8 months that cover a huge breadth of ways in which social determinants of health are affecting health outcomes and ways that they can be addressed. So spend time with those, introspection, and again, and we live in a racist society, so we need specific anti-racist policies. And that comes from the individual level to structural level to, kind of institutions, etc. For those who haven't read the book by Ibram Kendi, How to Be an Anti-Racist, like you can't just say I'm not a racist because unfortunately this is a society that racism is ingrained. So the default is that white supremacy is a default, so privileging folks who are white, who are male, who are English speakers, that's the default. So you all have to sort of be very active in contributing in the right direction. Thank you.
Thank you, Dr. Mungo, and all of our speakers. So we're going to try something that's different for us, maybe different for you as well. And we are going to open up 3 breakout rooms. So we're going to have a breakout room where there's going to be one of our panelists in each room. I'll be hanging out here in the main session if you do not want to move to the breakout room. But the purpose of the breakout rooms is so that you can have a chance to get to ask some of those questions that some of you have been sending into the chat. You can ask them directly to whichever speaker you think might best be able to answer those questions. So I am going to go ahead and get those breakout rooms opened up here.
Yeah, so like we said, this is our first time doing these breakout rooms. We'd love to hear your feedback at the end of the session. You'll receive an email after this panel, so we'd love to have you respond and let us know what your thoughts were, but we're hoping that by breaking into 3 separate rooms, more people will have the opportunity to ask their questions and get more one-on-one time with our wonderful panelists. So I believe you should receive an invite from Alexandria any minute now. Maybe.
Can anyone see them right now?
Nope.
Sorry, we'll hang on for a second. Did that work for people? Did you see it pop up?
No, Alexandria.
Oh, sorry, everyone. Let me try it one more time here.
That's okay. People are heading back, I think.
Do you want to just do the questions in the main room?
We can do the questions in the main room. We'll go with that. I'll play around with it as well.
Yes, let's go ahead and do that. So we do have some pre-prepared questions. These are questions that you guys sent in on your RSVP form. So I'm going to pull up one of those, and then you can keep sending your questions in the chat as well. So let's see. All right, so this first question is for Dr. Huchko, and it is, how would you make your practice or hospital a safe place for patients of color?
Thanks. So I would love to hear everyone others' perspective on this because as a white gynecologist, I have a different perspective when I go into a hospital setting. And I think it's really important to get diverse perspectives from race, age, gender, and power in what they feel will be what they feel would enable a non-stigmatizing environment where they can access and ask for and advocate for themselves and feel advocated for. So I knew you were going to ask me that, and I looked at ACOG, so the American College of OBGYN is seeking to reduce the racial disparity in birth outcomes throughout the country, but they are picking up on California's package of interventions to address the racial disparities. And so a lot of those interventions are about increasing the presence of underrepresented minorities in clinical staff and practice and leadership. Having representation matters, both as a trainee and in academics, but certainly as a patient. There is strong evidence, as Chemtai mentioned, showing that patients who are provided for by underrepresented minorities who are cared for by someone of their own stated race or ethnicity have better outcomes than those who are cared for by someone of a different race or ethnicity. So I think that's important. I think ensuring that the staff has training and embraces anti-racism and anti-bias measures, ensuring that you have measures in place to understand the structural and systemic factors that are impacting your patients, so you really can understand what the problems are, how your care might be contributing to them, how their experience and outcomes might be impacted, or at least it's different from patients that don't have some of those structural barriers. You know, when Nikki brought up her mom's experience, it breaks my heart a little bit because I feel like we have these templates where we have 15 minutes to see a patient, and you know, how can you make a patient feel safe and heard and be safe and heard with some of the constraints of modern medicine and time. I think there are people who do it really well, and I think Duke has actually put in some recommendations, very simple recommendations for us to have a patient state or clearly write out what questions they want to address before they even see any provider, so that you have that, so that you can wrap around at the end and make sure that those questions were answered. It seems simple, it seems almost a little bit silly, but I went to a gynecologist for the first time since my 6-year-old daughter was born a couple weeks ago, and she did that, and I felt like, you know, I don't have to do that. But at the end, you know, we came around to, these are the questions that I want to have, you know, that I want to have answered. And I think that's a way to sort of break down some of the barriers. And I think, you know, learning how to talk to patients well, and taking the time to understand them. There is training in trauma-informed pelvic exams. I think that's important. I think really, you know, asking them what their experience with the gynecologist office has been in the past. I do that for I'm in the colposcopy clinic now. I do that for every patient that I'm gonna do an exam on. Do you have any worries about this exam? Have you had problems with exams in the past? Because we want to be able to make this sort of the least painful and least fear-inducing procedure that we can. So those are some things to do in the office. I recommend reading about the ACOG bundle of practices to reduce racial disparities in maternal mortality. I think the question of how we get patients into the hospital is, involves much greater structural questions. Is how do we ensure that everyone has the right access to not just universal healthcare, but again, to give the example of where I'm sitting today, some patients are referred because they had an abnormal pap smear but live 2 hours away. So how do we get them into this office, and then how do they navigate an unfamiliar healthcare system where they have to pay for parking, potentially pay a facility fee. So I mean, I think within the office is one thing, how you interact with patients, how you interact with your staff, and how your staff and the team really work with patients is one thing, but how do we get them here in a way that makes them feel like we want them here and they belong here and they can get their care here is another set of questions.
Yeah, absolutely. Thank you for your answer. I'm going to move to our next pre-prepared question, again from the RSVP forms. This question is for Dr. Mungo. It says, what are the best ways to advocate for your health as a Black woman when the numbers show how Black women are continually marginalized and overlooked?
Yeah, thanks for the question. And I have to say that first, as kind of a medical community, the onus should be on us to make, like Dr. Huchko was saying, make patients feel safe and not have them, take on the responsibility. And I hope that that is something that this generation of physicians and health advocates are working towards. I think, finding a doctor that you feel like you can trust, that you feel listened to, is really important. And I know sometimes with the constraints of insurance, finding different doctors is not possible. But even within the your health system, some doctors are better listeners, some doctors are better XYZ. So really finding a doctor that you feel like you can connect with. And I think being honest and saying that, hey, if I'm pregnant, or I know that this is population level, Black women have higher rates of maternal mortality. What are you going to do to make sure that I'm safe? And really kind of holding that provider to account. Or have you undergone any implicit bias training, or what mechanisms does your hospital or institution have to address these issues? If patients can push your provider by asking, these are very legitimate questions. And I think most people are very well-meaning. Again, we all know what it takes to get into med school. You have to prove a million things that you're this good person, and people are, but it's just that we live in the society that's at baseline. There's a lot of factors that come in. So ask your doctor, if you're ever uncomfortable, if your family member is in labor, for example, or just any in the clinic, risk benefits alternatives, always ask that. What are the risk benefits alternatives? What are my options? And you can always ask for a second opinion. If you feel like you're getting, care that's, you don't understand it, ask for a second opinion. I think those are all things that are completely fair game. Studies have shown that, doulas in pregnancy improve outcomes for women. So if your loved one is pregnant and going to the hospital to deliver, having a doula there helps. I like the idea of pre-prepared questions and making sure that they're answered. But I think the onus should be on us as a medical society to really create the environments for patients to thrive. Thank you.
Yeah, absolutely. So our last pre-prepared question, and then we'll take a couple chat questions, is for Nikki. And I just want to reiterate what Alexandria just sent into the chat. I know a lot of you are sending in your chat questions. That's awesome. If we do run out of time today, we're not able to get to all of them, we have this chat saved. So we're going to make sure we address all of your questions in future blogs or videos. But for right now, this question is for Nikki. It says, as a non-BIPOC healthcare professional, how can I effectively regain the trust of patients of color in order to provide care where they feel their unique needs are being met and exceeded?
So I think my answer for this question kind of just echoes what Dr. Mungo and Dr. Huchko were saying about kind of addressing. I think one of the biggest parts of any visit is being able to address all the questions that a patient has, because I feel like that rather than just the physical diagnosis and whatever, all of that is inaccessible to patients if they don't know what it means. So I think that starting off with prioritizing what concerns, what worries, and what like external factors are influencing that patient at that point in time. Obviously, I'm not a healthcare practitioner, so I'm speaking from experience in terms of what I've seen, and what I've seen successful conversations and successful visits have been. They've been centered around patient advocacy, in the sense of not just advocating for the best medical treatment possible, but also advocating for some of the external factors that are affecting their lives. I was speaking to my dad about this just yesterday, and he said like one of my favorite my favorite doctors, the doctor that always is asking me about like Indian culture, asking me about like, oh, so like even just like Ayurveda, like all these different practices that might not traditionally have a place in modern medicine, but the curiosity and seeing the ambition on the provider to really be more curious about each patient and answering their questions. That's what I've at least seen has been a really effective way of regaining trust, is making sure that it's patient-centered rather than, diagnosis and like, this is our plan of action. Even though that is a very important part, I think just focusing on, treating each patient as an individual rather than just kind of the diagnosis, if that makes sense.
Thanks, Nikki. So I'm going to go to a question from the chat box. The question is, what are your thoughts and perspectives, Dr. Huchko and Dr. Mungo, on the medical algorithms that are based on race? An example is the VBAC calculator. These calculators are quite systemic and structural in the field. I'm also aware that some institutions like UCSF have decided to not use GFR, which is a similar tool. How can we change the conversation in OBGYN and reproductive health?
Chemtai, do you want to go or should I start?
Sure, I can start. Thank you for that question. Again, this is another example of just how institutionalized kind of some of these biases are and can kind of be perpetuated. Right, so when you in training, you learn about the VBAC calculator, which is basically a calculator that's used to determine the chance of a successful vaginal delivery for a woman who's previously had a cesarean section. And there's this correction for race or ethnicity, which reduces the probability of success, particularly for Black women. And something that, when I was in residency was just a given. This is when you have a woman who's coming in who's trying to have a vaginal delivery after C-section, it's like, what's her VBAC success rate? So as a young trainee, like, oh, great, this is what we do. But turns out there's really no concrete evidence for why we are correcting for race and reducing the chance, the probability is based on race. And this is something that, again, bringing an anti-racist framework to medicine, and being curious and asking questions, and it's really and now we're realizing that this is not evidence-based. I think the more of us, as you start your medical journeys in whichever fields, like be curious and ask, why are we doing this? When you're sitting in medical school class and you're told, oh, African Americans have increased risk of diabetes, like ask your professor why, and they should go on and explain the structural factors, food deserts, etc., that put people at risk. We know that race is a social construct, but medicine traditionally has, kind of ascribed this risk based on race and really not racism, or the structural racism, the environmental racism, and there's a drive now in the community to talk about racism as a risk factor and not race. That's something that I encourage folks out there to read about. So this is an example of having more kind of aware, engaged, curious, anti-racist mindsets by all of us can bring to medicine and challenge the people that teach us medicine, why it is that we default to these patterns that often have roots that are not evidence-based.
Yeah, I will add to that. I think that, you know, the VBAC calculator, I feel like there's a lot of negatives to having that kind of calculator. Everyone, you know, since it's convincing people not to do something that doesn't necessarily harm them. But there is, you know, I have a couple thoughts on this. There's a recommendation by the Society for Maternal Fetal Medicine and ACOG to give aspirin to women to prevent preeclampsia. And it's really been shown to be one of the first really effective tools we have to reduce the risk of preeclampsia, which is the condition where women develop high blood pressure and they could have systemic effects like a stroke or problems with their liver or vision or seizure at delivery. And it can also impact the fetus. So giving a baby aspirin throughout much of pregnancy reduces the risk of that happening. And if women have moderate or high risk factors, they should be offered aspirin. And one of the moderate risk factors is African-American race. And another of the moderate risk factors is low socioeconomic status. So I take care of patients in the health department, and we've had this debate multiple times, like how do you separate, what is the racial fact that or the racial contribution of having this risk factor. And, you know, essentially it's if you have two moderate risk factors. So if they're in the health department, and they're Black, they have those two moderate risk factors and they're getting put on aspirin. And so I brought it up, we've talked to leadership about this, and then I'm taking a class through Duke on health disparities research. And during the first session, someone brought up the question for conversation, why should we even include race as a variable in research? And the organizers of the course said, well, you know, I think that you can debate either way on that. If including race identifies increased risks that can be addressed for people of color or Black people or women, you know, certain ethnicities, then there is a value to including it in research. But if we don't include it correctly, so looking at the structural factors and the racism that leads to those poor outcomes, then we're not going to be able to to improve or address the health outcomes. If you take that down to the fact that if you put women on aspirin, it will reduce the risk of having preeclampsia. So is it fair to use race in that case without looking at the more subtle and structural factors that contribute to their increased risk of preeclampsia? You know, I think that it was pretty enlightening to have this conversation within the health disparities research course leadership that, you know, how do you have to do it correctly, and how do you use some of these outcomes that could potentially, maybe we're not arrived at in the most, you know, in a way that directly looked at racism, but could still have a positive health impact. Or someone was looking at health disparities in cancer, gynecologic cancer outcomes. What's important in those cases to be able to highlight the different groups have worse health outcomes, so you can look into why that is. So there's still some benefit to using it in research. It just needs to be applied correctly to the next step in research and to clinical care. I think the VBAC calculator and the modified GFR are good examples of how it doesn't contribute anything positive to health outcomes.
Thank you, Dr. Huchko and Dr. Mungo. So to close off our time today, we're going to end with one question from the chat box that kind of sets the tone for what we can all start doing as we move forward from this conversation. The question is, which books do you all recommend to educate ourselves on these issues? So I would love to know if any of the three of you have any suggestions on books, blogs, podcasts, ways that our participants today can not just let this be an hour-long conversation on a Tuesday, but something that they can continue to learn about in their own time.
I will echo the recent series by the New England Journal of Medicine called Race and Medicine. There's really excellent perspective pieces by predominantly Black physicians around the world, or people doing health disparities work on very different facets of kind of health disparities. And recently there was an article about reparations as a public health priority. And obviously reparations is something that's very controversial, but Dr. Mary T. Bassett, who's this very respected epidemiologist, makes a really good case for the wealth gap being very intricately connected to health outcomes. There was an excellent piece back in 2019 by Dr. Deborah Cohen, who's an OBGYN at UCSF, called Racist Like Me. Provocative article title, but basically talking about how even she, who's a very well-meaning, very, kind of an ally who's woke, everybody knows her, there's this insidious ways that, racism can play in how she treats patients differently. And really a call to action for this to be like a continuous work amongst other ways to address this issue. So definitely, and they're really short articles, very insightful. I would recommend checking them out. Thank you.
I just quickly, the last panel was actually on medical bondage, which I'm sure everybody has heard of before, but I just want to reiterate how important it is that for me, I really like to revisit history and see how kind of we got to this point, and to kind of draw parallels between what happened in the past in terms of the origins of gynecology, and revisit and see how what's happening today, and kind of questioning the practices. So I think that reading Dr. Deirdre Cooper Owens' Medical Bondage has been really insightful for me, specifically just drawing parallels between today and the past and seeing kind of how there's so much work to be done, because some practices are definitely continuing. So that's just from my perspective.
And I'd recommend the immortal Henrietta Lacks, just to look at what unsung contributions this woman made with her cervical cancer cells, and how much they've really shaped modern medicine without any sort of attribution, not just modern medicine, but profit for modern medicine, without any attribution or financial compensation to her family until the book was published. There's a book called Black Man in a White Coat that's written by a cardiologist here at Duke about his experience training as a Black physician at Duke not very long ago, and some of the shocking things that happened to him. And then for a really short read, but I think important, there is a blog called On Racism, a new standard for publishing, and it's written in the Health Affairs Journal. A former colleague of mine at UCSF is one of the co-authors, and she really writes well on and passionately on what is the point of using race as a variable, and points out how often it's used but not really explained, and makes 3 specific calls for the medical research community to change the way that they think about race versus racism. And, I think that's an important one to have in your pocket when people talk about, question maybe some of the data on racial outcomes. And it's a pretty easy read.
Great. Thank you guys so much for sharing your answers there. Thank you so much to everyone that joined us today. This is the end of our panel. We want to again remind you, after this panel, you're going to receive an email from us. We really appreciate you cooperating with our first time doing this via Zoom. We'd love to hear your feedback. We'd also like to invite you to join us next month for our next Facing Hard Numbers and Harder Conversations panel, where we'll be discussing disparities in healthcare access for the LGBTQ+ community. So thank you again to all of our attendees, and thank you so much to our panelists. I hope that you had a great time with us this evening. This video, a video recording of this panel will be posted on our YouTube in the next couple of days, so stay tuned for that. And again, just thank you so much.
Thank you. Bye-bye.
Thank you. Bye.
Bye.